Hi, my name is Justin Gardner. I'm the current Emergency Medicine Wilderness Medicine Fellow with Virginia Tech Carilion Hospital in Roanoke, Virginia. I'll be presenting the hot and cold section of AWLS. This covers heat illness, hypothermia, and frostbite. There's four methods of heat transfer into and out of the body: radiation, conduction, convection, and evaporation. Evaporation is only heat loss. With radiation, it is the transfer of heat between the body and environment through electromagnetic waves. It accounts for about 50% of body cooling as long as the environmental temps are less than the body temp. With conduction, it is the transfer directly between objects in contact between the body and another object. The heat loss is overall minimal unless it is with water immersion or lying directly on cold ground. Convection is heat transfer between the body and a moving gas or liquid, usually water or air. The rate of heat transfer is dependent on the speed of the flow of air or water or the temperature of the substance. It accounts for about 25% of heat loss or gain. Wind chill factor is due to this. An example is if a person is submerged in 60-degree water, they'll maintain consciousness for up to 2 hours. If they're in 32-degree water, they'll lose consciousness in as little as 15 minutes, to show how different rates in temperature of water affect body temperature. Evaporation is the most efficient cooling mechanism. This will come more into play with our heat illness section. This also includes respiratory loss and sweat. As an aside, respiratory loss would be more significant for young children. This accounts for about 30% of heat dissipation as long as it's average external temperatures. This becomes a major cooling mechanism once we reach environmental temps above 95 degrees. With evaporation, once humidity reaches about 100%, the body is essentially unable to cool through evaporation, which is why the heat index is in place. It accounts for the difficulty with evaporation due to humidity. Overall pathophysiology is that overall our species tolerates heat much better than cold. The overall problems arise when there's an imbalance between heat production and heat loss, and dehydration complicates this significantly. Each patient, each case is unique. So we're going to start off here primarily with heat illness. Objectives are recognizing signs and symptoms of heat cramps, heat syncope, exhaustion, and heat stroke. We're going to review treatment of heat illness, discuss prevention techniques, and guidelines on when to evacuate. So physiology of the body with heat. There's shunting of the blood, which is cutaneous vasodilation, while there's also concomitant splanchnic vasoconstriction, so decreased flow to GI tract and kidneys. You get a increased cardiac output as well as peripheral vasodilation, so you get increased heart rate as well, which goes along with the cardiac output. You get increased catecholamines leading to activation of sweat glands. The hypothalamus is regulating reduction of heat production as well, so reducing metabolic heat production. Heat illness occurs when the body kind of loses its ability to appropriately dissipate heat. Physiologic responses deteriorate as the cardiac output reaches its limit and is unable to kind of increase the flow to the skin, allowing dissipation to occur. You also get worsening electrolyte losses and dehydration, worsening the heat illness as your sweating significantly increases. Increased risk are conferred with these factors. You have medical diseases such as cardiovascular problems, dehydration, vomiting, diarrhea, fever, also endocrine problems like diabetes and hyperthyroidism. Medications like beta blockers, antihistamines, anticholinergic diuretics, ethanol lead to higher risk. Obviously, being in a hot environment, if you're not properly clothed, or you haven't acclimatized to exercise in hot environments, or you haven't properly hydrated. If you've been exposed to heat illness in the past, you can have worsened heat illness in the future. also, as well as if you're dehydrated as prior, or patients that are not fit or overweight will have higher risk. There's overall 3 stages: acute, enzymatic, and late. The acute set is activation of inflammatory mediators, and I'm going to go through my notes as well. The acute phase, you have hypoperfusion to the GI tract. You can lead to sort of like a ischemic gut and SBP. You get migration of bacteria from the gut to the blood. You can also have a primary respiratory alkalosis from hyperventilation, as well as a second primary metabolic acidosis from increased glycolysis and hyperprolactinemia due to excessive demand on the body. With the enzymatic phase, you eventually will see DIC. You have disturbance of coagulation cascade. You have both increased coagulation and fibrinolysis. You have diffuse microvascular thrombosis and endothelial injury, eventually leading to DIC. And then the late phase almost entirely comes about through to the DIC from the enzymatic phase. You get multisystem organ failure. You get cholestasis and hepatocellular dysfunction from DIC, and that usually occurs in about 12 to 24 hours. You also see renal failure, cerebral edema, petechial hemorrhages in the brain, neuronal degradation. You'll also see hypotension and death if cardiovascular dysfunction progresses far enough. Overall dehydration, it's hard to notice the early signs. By the time you feel thirsty, you might already be down by 1 to 1.5 liters. Initially, you'll see dry mucous membranes, dark urine, mild thirst. When you reach moderate stages, you'll have very dry membranes, darker urine. You'll have a weak, thready, rapid pulse. With severe phases, the patient will be altered. They'll have essentially no urine output, no tear production. They'll be in shock. So our first and one of the more milder heat illnesses is heat cramps. Very painful muscle spasms. They are generalized, but they may be unilateral. They are resultant from replacing body fluid losses with a hypotonic solution. Basically, with relative hyponatremia, you have involuntary and sustained skeletal muscle contractions. Unfortunately, it's not resolved with stretching like a typical exertional cramp. Really, the only treatment is rest, time, and proper rehydration. Severe cases, you can give IV normal saline, but when you're actually out in an austere environment, just get out of the heat, get in the shade, take in salty foods or salt-containing fluids. There are salt tabs. There's also ways that you can make this on your own. You can take half teaspoon of salt, mix that with 6 teaspoons of sugar into 1 liter of water. Or if you just have like a sports drink, you can mix that 50% with water, and that'll lead to a proper electrolyte balance. Heat edema is basically edema that you get in the lower extremities. It's due to vasodilation leading to interstitial edema. It's both in the hands or the feet. It's benign. It'll go away on its own. It's non-harmful. Treatment is just keeping the body parts that are affected elevated. Make frequent voluntary contraction of muscles, so stay active. You can wear compression stockings while you're out hiking. With heat syncope, it is basically a type of orthostatic hypotension. It's not so much due to dehydration as typical orthostatic hypotension, but it is very similar. Patient is not typically that hyperthermic. It is more common in patients who are not acclimatized. Typically occurs when patients are standing still for long periods of time outside in warm environments. Patient should be lied flat, passively cool them, take them into a shaded area, cool area. If you have a fan them, get them fluids. Loosen any tight-fitting clothes. And don't just assume this is heat syncope. Assess for other potential causes of syncope, like hypoglycemia, any type of cardiac arrhythmia, anything else that could be concerning as a type of cause of syncope. Excuse me. Heat exhaustion it's a significant heat stress leading to intravascular volume and sodium depletion. The initial symptoms are weakness, lightheadedness, fatigue, nausea, with or without vomiting. Patient will have a headache and be intensely thirsty. Patient will be tachycardic and tachypnic, though they can be profusely sweaty or diaphoretic. Not always, though. They can have some loss of sweating once it gets more progressed. They may or may not be hypertensive, but if they are, or sorry, hyperthermic, but if they are, it should be less than 104. It is along the continuum of heat illness, and progression of this is heat stroke unless you can abort the process before it reaches that. Treatment is, again, loosening clothing, giving them fluids, remove them from the dangerous environment, rehydrate, as we've already discussed. The goal is about 1 to 2 liters input over 2 to 4 hours. If they are hyperthermic, then you can begin cooling them. So cooling uses both evaporative and convective cooling. You basically douse them in, try for ambient temperature water. It helps prevent shivering because the body's shivering response is brought about by the perception of temperature of the environment. The body's unable to assess for the temperature of the core temperature. So if you douse them in ice water or very cold water, they'll begin shivering inappropriately, which will then increase metabolic demand and make it much more difficult to cool them. It also allows for maintenance of the vasodilation, which will allow for better heat dissipation. So you make them wet and then you fan them and repeat this process until symptoms significantly improve. So once you reach a body temperature of about 104 or above, is when we start to classify this as heat stroke. You will see CNS disturbances, and this does become a true medical emergency. The classic definition is conservative, and that is basically no sweating. But as a quick aside, I'm going to pull up a second PowerPoint I've made in the past. It goes over an example. So a key point is, don't determine your diagnosis of heat exhaustion versus heat stroke solely off of the presence of sweating. And an example, Corey Stringer was an offensive lineman for the Vikings. And on day 2 of the preseason training camp for the 2001 season, it was a 2-day practice. He completed the morning session, and by the time the end of the practice, I think it was 11:30 a.m., heat index was 99 degrees. So it's 2.5 hours of practice in full gear. He began vomiting. He was weak, dizzy. He collapsed on the field, quote, babbling and nonsensical. And that was by a quote from another teammate. The trainer took him into the air-conditioned trailer, started an IV, gave him fluids, but they thought there was no way it could be heat stroke because he was sweating. They kept him in the trailer for an hour, and then he began to have a seizure. They called 911. By the time ambulance arrived, he was already unconscious. They checked a core temp upon arrival to the emergency room, and it was 108 Fahrenheit. He remained unconscious throughout his treatment, and he actually died by the next morning. So don't base your heat stroke versus heat exhaustion diagnosis based on the presence of or lack of sweating. So more findings, particularly for heat stroke, is ataxia is a very early finding, mostly because the cerebellum is the most prone part of the brain to heat illness. The patient will become irritable, they'll be confused, they'll be combative, They can develop hallucinations, seizures, syncope, but more of like recurrent syncope or prolonged loss of consciousness. They can develop hemiplegia, decorticate or decerebrate posturing, and coma, which is a late finding. Treatment for this is basically heat exhaustion treatment plus. So give IV fluids if they're available. The goal is 1 to 2 liters within the first hour. Monitor frequently for pulmonary edema. So instead of prior, when you don't want to douse them in cold water, you want to get them basically immersed in water. It doesn't have to be freezing, but you want to fully submerge them if you can. It will be faster than just dumping them with water and fanning them. It's going to be difficult in most wilderness settings. Further goals are dropping the temperature below 104 degrees Fahrenheit as fast as possible. However, and it will be tough in the wilderness setting without proper thermometer access, but stop at 102.2 Fahrenheit because you can overshoot and then cause hypothermia. The body will continue to cool once you reach a certain temperature. So you stop at 102.2, so then it'll drop slightly lower, but you won't induce shivering. And then evacuate to definitive care as soon as possible. Prevention for heat illnesses is maintaining good hydration. The goal should be to produce clear urine. Eat salt-containing foods and beverages instead of just like the sugary, carbohydrate-dense foods that most people go for. Make sure you drink proper fluids and high salt-containing snacks. Wear loose-fitting clothing and light-colored clothing. Stay out of the sun if you can. And if you need to, douse yourself or clothes with cool fluids. Prevention can also be done by acclimatizing. As an adult, basically expose yourself to exercise in the heat for about 60 to 90 minutes per day for 7 to 14 days, or 8 to 10. For kids, they'll require more like 10 to 14 days, as will the elderly. You can also stay in a sauna or a steam room, but physically exerting yourself will do better than that. So next up will be hypothermia. We're going to cover the pathophysiology of hypothermia and frostbite, as well as recognize and treat hypothermia and cold injury in the wilderness. We will understand the evacuation criteria for frostbite and hypothermia, and discuss prevention of these conditions. First off is a case. This is actually the second lowest body temperature ever seen in a patient who lived. She was a 29-year-old skier. She went down a ski route she knew very well. She was actually a orthopedic surgery resident in Norway. And after a shift, she went skiing with colleagues. She went down a ski run she knew well. She fell backwards, and then her head and her torso fell through and then fell through a hole in the ice. The ice was 7 inches thick. Underlying that was a stream. Luckily, she was able to find an air pocket above the stream, but still under the ice. So she had air and didn't drown. She remained trapped for 80 minutes. Her friends called 911 several minutes after they couldn't extract her themselves. It took one rescue team who failed to get through the ice, and then a second rescue team to finally get her out of the ice. When they got her out, she was lifeless, pulseless, fixed and dilated pupils. They began CPR. It took about an hour for them to get to the hospital. She had a core temperature of about 57 degrees Fahrenheit on arrival to the hospital. Total resuscitation time of about 9 hours. They started cardiac bypass and then converted that to ECMO. She remained on ECMO for 5 days. She remained on the ventilator for 35 days, woke up paralyzed, but regained almost normal function with significant rehab, and she's now practicing in as a radiologist. Um, it's either at the hospital she was saved at or the hospital she was an orthopedic resident at, one of the two. So pretty significant case and great save by that team. Um, this is another example of why you never assume a patient is dead until they're warm and dead. Kind of back to the methods of heat transfer. Radiation is responsible for 50% of heat loss in low temperatures. You prevent it by appropriately dressing. Conduction is the same with, we talked about prior, with water immersion and wet clothing. Convection is, again, the wind chill factor. Evaporation is primarily in dry, windy environments. With heat production, you see that with shivering. It's essentially our only way of producing heat. The hypothalamus is what regulates this. And again, as I mentioned prior, it's like your skin's sensation of the environmental temperature that is what the body is assessing. The body also will lead to cutaneous vasoconstriction of the skin and extremities. And hypothermia in general is a temperature under 95 degrees Fahrenheit. You have increased heat loss with poorly insulated clothing, wet clothing, and anything that leads to vasodilation, such as ethanol. Vasoconstriction is energy requiring, so maintaining that takes energy, and eventually if energy runs out of the body, then you lose vasoconstriction. This loss of vasodilation significantly worsens the body's ability to maintain body heat. Strangely enough, with what's the resultant loss of vasoconstriction and then the secondary vasodilation, you get a blood rush to the skin. The skin senses that as warmth, and then the person will feel warm, so then they'll feel hot in their clothing. They'll take their clothing off, despite basically being in early stages of hypothermia, or at least mild to moderate. This is called paradoxical undressing, and it's also associated with the patient becoming altered from the hypothermia. Then this obviously drastically worsens the rate of heat loss. So mild hypothermia is less than 35 but above 32 degrees Celsius. It is a state in which the cold defense mechanisms, essentially shivering, are still working. Body is pale because vasoconstriction is still in place. Patient will become somewhat impaired with poor judgment, confusion, and disorientation. They will develop cold diuresis, where urinary frequency will increase. They'll lose fine motor skills. Patient will be tachycardic, hypertensive, and tachypnic. Once you reach more moderate stages of hypothermia, which is between 28 and 32 degrees Celsius, it's a worsening of a patient's level of consciousness. They'll become, they'll have slurred speech, they'll have dilated pupils. Now they'll have bradycardia, hypotension, bradypnea, they'll have a slow breathing rate. They will develop muscle rigidity, and they lose the ability to shiver. So now the body is no longer able to effectively rewarm. The body also becomes prone to cardiac dysrhythmias, and now leading into severe hypothermia, which is between 24 and 28 Celsius. Patient will essentially become comatose. They'll develop fixed dilated pupils. Muscles will become rigid. Most likely not be able to palpate or assess for a blood pressure or heart rate. They can appear apneic, and their heart rate can drop as low as 10 to 20 per minute. Skin will appear cold and cyanotic, and they are very prone to dysrhythmias. Profound is any core body temp under 24 Celsius. Very, very low rate of survival. They will basically look lifeless and high possibility of cardiac arrest. It's called the modified Swiss hypothermia staging system. It's kind of just breaking it down easier. from mild to profound hypothermia. It's basically trying to go based on just clinical symptoms. Obviously, you're not going to have a rectal temperature probe in the wilderness setting, most likely. Treatment, as far as mild hypothermia is concerned, you start out with taking the patient from the cold environment, taking off any wet or cold clothing and putting on dry, if you have it, slightly warm clothing. If the patient is able to, you can have them begin walking once you give them something to drink, something to eat to replenish energy. After about a half an hour, as long as they look stable, you can have them mild exercise. You can allow them to do that. Um, the body is able to produce heat through shivering, so they can hopefully rewarm if you give them the capacity to do so. With moderate hypothermia, you can begin active rewarming. You can do skin-to-skin contact, which is basically if there's enough personnel and it doesn't delay time to extrication, you can have one rescue member in skin-to-skin contact with the victim. You can give warmed IV fluids if they're available. You can apply heat to the areas that are primarily losing heat, such as the head, the neck, chest, back, armpits, and groin. You have to evacuate for active rewarming. Patient is not able to rewarm themselves. With severe or profound hypothermia, you have to do active rewarming. Again, they're not able to rewarm. Keep them supine if you can, because any change in body position can lead to dysrhythmias. Limit any jostling or movement for the same reason. Evacuate as soon as you can. Again, nobody is dead until they're warm and dead. Patient will and can look basically lifeless. However, a caveat to that is if they have what we call an ice mask, which is snow, ice, debris filling the airway. I mean, there's no chance that they have been or are able to breathe. So you have to assume they asphyxiated rather than died from hypothermic arrest. If they have an obvious primary traumatic cause of cardiac arrest, if they are frozen solid, or they are obviously an asphyxiated patient, then you can assume that they are actually cold and dead. As far as evacuation is concerned, again, if they're mild hypothermia, you don't have to evacuate them as long as they're given the ability to get dry clothing, a safe environment, and they're active in their own care. Anybody moderate or worse must be evacuated. And if necessary, you can bypass a close facility as long as a higher level facility is about an hour or less away transfer if they have cardiac bypass or ECMO capabilities. For prevention, look at the weather forecast, know what you're getting into, bring proper gear, have a contingency plan, backup plan, let people know where you are, stay well hydrated and well fed, and bring food and liquids to maintain that. Wear layers so you can increase and decrease the amount of layers you have on. This is text that I already went through regarding that case. Now on to frostbite. It can occur anywhere in the body, most often the extremities, but yes, it can affect fingers, nose, ears, sometimes the face if they're exposed. There's overall 4 phases: the pre-freeze, the freeze-thaw, vascular stasis, and ischemic. Cooling and eventual freezing of body parts does lead to an intense inflammatory reaction after thawing, which is basically the vascular stasis and ischemic phases of this staging system. Phase 1 is skin temperatures between 37 and 50 degrees Fahrenheit. You develop a vasospasm with decreased blood flow. There's instability of the cell membranes. There's endothelial plasma leakage and vasoconstriction with the lower skin temperature. Next is the freeze thaw, which is when the tissue actually drops below 32 degrees Fahrenheit. You develop formation of ice crystals, and with a fast freeze, you develop intracellular crystals. A slow freeze, you develop extracellular crystals, and which is much more damaging. You get shrinkage and death of cells and fluid shifts across the cell membranes. Phase 3 is vascular stasis. Again, it's after the tissue has been thawed. Inflammatory mediators play a large role. There is vasospasm and dilation of the affected areas, vascular shunting, and a microvessel thrombosis, and plasma leakage. With the ischemic phase, it's again secondary to the inflammatory mediators. There can be large and microvessel thrombosis, AV shunting, ischemia, autonomic dysfunction, and eventual gangrene. Frostbite is divided into first through fourth degrees, as well as superficial through deep. It's initially difficult to determine the staging. It's actually not appropriate to stage until the skin has been thawed, but you're supposed to also have determined this prior to definitive detailed imaging. So it's not really that pertinent for the actual austere setting, other than knowing it is significant enough of an injury, regardless, to require evacuation. To simplify this, superficial includes first and second degree, minimal anticipated tissue loss. With deep, it is third and fourth, and there is going to be tissue loss. Excuse me. So for first degree, again, includes the superficial skin layers. The skin will appear pale and yellow, and it will have sort of a raised plaque. The area is numb, and with rewarming, it will be painful, and the area will be red and swollen for several hours. Second degree, again, skin is pale and white. They'll have the raised plaque. They will have blisters that are typically filled with clear to yellow fluid. Can be white in color as well. Again, it will be painful on rewarming and will be swollen red for several hours. Third degree is complete freezing of the skin, including the dermis and subcutaneous tissues. The skin appears pale and white. That area is numb, and with rewarming, there will be swollen and red skin for hours, if not days. With third degree, you get blisters that are now filled with hemorrhagic fluid. So those are the blisters that are reddish or bluish, purplish coloration. Fourth degree is deeper still. It can include muscle, tendon, and bone. The area is pale and white. It will feel on palpation like a chunk of wood, is the classic quote. With rewarming, it'll be very red and swollen for days, and they'll also have the hemorrhagic blisters. Here are some pictures here. So it is a good example of affecting the ear and the tip of the nose. For treatment, thawing is extraordinarily painful. However, a poor thawing process will cause a lot of harm. If you thaw them too quickly, the inflammatory process will be significantly worsened. If you expose them too high of a temperature, they'll now have a burn on top of their frostbite, which is why fire, like an oven, a space heater are not appropriate ways of heating or rewarming a patient, because they're numb, they can't feel it, they might get too close or actually burned. Instead, you want to rapidly warm them with water. So only do this, though, if there is zero chance of any refreezing, because refreezing is much more damaging than the initial freezing. So if you can, have a circulating bath of water, warm to about 98.6 to 102.2 degrees Fahrenheit. If you can't measure that with a thermometer, it would be like a warm bath or a hot tub temperature. Keep the affected part of the body in that bath for 15 to 30 minutes, or until the skin is pliable and returns to its normal temperature. Beyond that, remove any wet clothing, give them dry, if you have it, warm clothes. Take off anything tight, especially rings or jewelry on the fingers. It will definitely lead to worsened ischemia if you leave those on. Um, if you can, separate fingers that are affected. Wrap each finger individually with gauze, because the friction from rubbing can be very damaging to tissues. And that brings up another point: never rub anything that has been affected by frostbite. Um, we mentioned the intra and extracellular ice crystals earlier. Rubbing basically grinds all of those crystals against and into the different parts of the cell layers. If a patient is not going to be rewarmed in the austere setting, then you can splint them, but allow function, because they're going to have to aid in their own extrication. So splinting them will lead to decreased rates of injury. However, that way they can still move and be functional at the same time. If you are thawing, then you don't have to splint, because you want them to get the best blood flow they can. And kind of as an aside, if you do splint them and you're having them help walk out themselves, they are getting improved circulation just by helping extricate themselves. Again, if you're splinting, elevate that part above the heart if you can. Again, the thawing process is extremely painful. So they were likely going to require narcotics. Also give them NSAIDs, and ibuprofen is recommended, even over aspirin. This dose here is the dose that would lead to decreased inflammatory cascade. It will most likely not be enough to additionally help with pain. The recommendation for the pain threshold would be 12 milligrams per kilogram per day divided into 4 equal doses, up to a maximum of 2,400 milligrams per day. Also give them the tetanus immunization, because it's a high risk wound. You can give aloe vera topically. It will actually reduce the prostaglandin and thromboxane production. Antibiotics are by choice. They're not strictly recommended. Once you reach a hospital, rapidly rewarm them, give them strong pain medications. As far as debridement of the blisters is concerned, only drain the clear fluid-filled blisters. Do not drain the hemorrhagic blisters. The hemorrhagic blisters actually contain a lot of products that will aid in healing. And if you're going to drain any blisters, you do it with a needle. You just aspirate the affected blister and then apply a dressing over that. Only drain them if they're limiting range of motion or ability to help the patient extricate themselves, or if they are obviously about to burst and you want to maintain sterility as best you can. As far as thrombolytic therapy is concerned, this may actually determine where you evacuate the patient to, similar to hypothermia. If a small critical access hospital doesn't have TPA, then you might want to bypass that to go to somewhere that does, because medications like iloprost or IV or intra-arterial TPA have been shown to significantly reduce the degree of amputation required. Avoid refreezing. As again, I mentioned earlier, refreezing is significantly more damaging than the initial freezing injury. If there's any chance that they're going to refreeze in this austere setting, don't thaw them. Allow them to aid in their own extrication. It's better to have them walk out on a frozen foot than to thaw it if it might refreeze. As far as the do nots are concerned, we mentioned don't expose them to a flame or a significantly dry heat. They will possibly burn themselves. Do not massage the area. I know at the bottom it says don't rub or snow. I thought that was funny. That was actually a recommendation until 1950, was to rub a frostbitten area with snow. Don't do that. Um, this is just a quick example with good picture slides of a patient who was hypothermic after becoming lost and falling in a river. She changed appropriately. She changed all of her clothes, but she forgot to change her boots. Um, and she was finally out of that setting 36 hours later. They did rapidly warm her feet in 40 Celsius water. They gave her fluids, gave her Toradol for pain meds, and applied Silvadene. They warmed IV fluid bags and kind of laid those on her toes, kind of like chemical warmers in a sense. Um, Toes did not really improve that much by the next day. Um, Discharge instructions, basically, she was told to bathe her feet daily, apply Silvadene. She required aggressive pain management. She later required debridement several times, and she did eventually have several amputations. So this is 2 days. So you can see each toe is affected, but to differing degrees. A week later now, left foot, the first 3 toes are obviously the most affected. Now 7 weeks later, and you can see how much progression you can see with that. 3 weeks now, and she has had debridement and amputation of the affected toes. To prevent frostbite, minimize heat loss, maintain hydration to improve good blood flow, cover all exposed areas, minimize anything that would restrict blood flow, so don't have overly tight clothing or footwear or gloves. Exercise can increase the core temperature and leading to increased peripheral temperatures that can help prevent frostbite. Frost nip is less severe than frostbite, but it is sort of how heat exhaustion is a prior event to heat stroke, but along the same spectrum. The affected area will appear red and swollen. The skin, however, does remain soft and pliable still. Patient can have numbness and tingling. So it might be difficult to tell the difference between frost nip and frostbite, but the main differences are the skin and tissues are still soft and pliable. With treatment, again, don't rub the areas. It's similar in thought to not rubbing frostbite, but as opposed to frostbite, you always rewarm this area. Even if there is a risk of further exposure to cold, preventing frostbite, progression to frostbite, is done by rewarming the area. So it's not yet damaged, you're preventing damage by rewarming for frost nip. Chilblains is also known as Pernio. It's an itchy, painful, bumpy rash. It's when you're exposed to temperatures that are just above freezing. It's associated with, poor circulation to the tissues, rapid rewarming, or sudden exposure to cold and damp conditions. Here's a picture down at the bottom right. You can also have blisters that occur, and you can have this persisting for up to 1 to 3 weeks. Treatment is obviously keeping it warm and dry. You can apply lotion or steroid creams. Benadryl can help with the itching. As far as evacuation is concerned, any patient with frostbite requires evacuation. Frost nip, chilblains do not. And this was not included in the AWLS lecture, but it is in the book, so I wanted to cover it real quick. Immersion foot or trench foot is exposure to water at non-freezing temperatures for prolonged periods of times up to several days. It is when the temperature is between 32 and 50, so again, non-freezing. The skin will look red, swollen, and then you can develop the blue discoloration. Again, usually the foot will appear shiny, and the patient may have numbness, tingling, pain, and again, feel wooden. Patient will have blisters, ulcers, can develop gangrene, but that's rare. Most cases resolve spontaneously. Treatment is keeping the area warm and dry. This does not also require extrication as long as you can prevent worsening. Evacuation again for heat illness would be heat stroke is emergent evacuation. Anything less than heat stroke does not require evacuation unless a patient's core temp is over 102 or they have persistent uh, uh, loss of consciousness, any recurrent loss of consciousness, um, inability to properly get them out of the hot environment or into a safe setting, inability to provide cooling where you're at. But if you can provide cooling and successfully resuscitate them there, they avoid any exercise for 24 to 48 hours. They can remain in a non-hospital setting. Um, for questions, I'll also be giving the video lecture on patient assessment. I'll be covering the actual video portion, like a mock patient assessment. So you can ask me questions on this and that, either in the in-person skills demonstration session or the Zoom video, like disease, infectious disease portion. So thanks for your time.